in. And I'm not very savvy with Zoom, so I'll go ahead and apologize if I have issues. Okay. I'm trying to make my slides work here. Okay. Alrighty, so just a basic overview. I'll give you guys a case, like a fairly common case that we see in the hospital. And then after that, we'll dive into some of the physiology and pathology of pneumonia, and then some of the diagnostics and the diagnostic pitfalls. That's really the meat of this. It's the diagnostic pitfalls that I'm really going to harp on a lot. Then management, and then a few key points and take-home messages, and then we'll wrap things up after that. Okay, so here's just kind of a very common case that we've probably all seen various forms of. A 71-year-old man, past medical history significant for end-stage renal disease on hemodialysis, type 2 diabetes with a slightly elevated A1C, GERD on a PPI, multiple prior episodes of aspiration pneumonia, who was admitted from his assisted living facility with sepsis. He's afebrile, tachycardic, and his blood pressure is a bit on the low side. White count is 13, lactate is elevated. Procalcitonin is kind of non-committal at 0.6. And then his chest x-ray shows some basilar opacities read as pulmonary edema versus infiltrate. To further complicate things, he's confused and not able to give a sputum sample. Because he's just not able to follow directions. I feel like this is a patient that I see like some variation of 3 times a week when I'm on service. It's just, there's just a lot of pitfalls. There's a lot of confounders. We can't always get great diagnostics. And so what do we do with these patients? They are challenging. So that's kind of where we'll springboard off of for this and dive into the deeper aspects of pneumonia care. All righty. So in a community-acquired setting, the basic definition of this is that they haven't had any inpatient contact in 90 days, and that includes from a nursing facility. So patients that come from a nursing facility are in a different category as far as what their microbiologic risk factors are. The patient I just talked about, I made sure that he was from an assisted living facility just to stick with this topic of community-acquired pneumonia. But here's the pathogens. I color-coded them by gram-positive, gram-negative, and then atypical. So the gram-positives that we most typically see are Strep pneumoniae, by far and away the most common pathogen for community-acquired pneumonia. I feel like we've been seeing a fair amount of Staph aureus in some of these cases. And then other things that we'll see, H. flu, Moraxella, and then for atypicals, Chlamydophila pneumoniae, Legionella once in a while, and then Mycoplasma pneumoniae as well. We can also have viral pneumonias, including COVID. We are all very fed up with COVID, and I don't really want to talk about it anymore. And then flu and A and B, and RSV, parainfluenza, adenovirus, human metapneumovirus, rhinovirus, and other things. There's always something new coming out, I feel like, with the viral infections that we're seeing. And I feel like we were just talking about this year, I feel like we're seeing higher levels of pathogenicity for some of the known viral infection agents that we've known and seen circulate around for a long time. For some reason, people are just getting sicker from them. It's important to note that viral infections can come along. They're easily transmitted in the community, as we all know, and then they can do enough damage to your lung parenchyma to where the bacterial infections can take hold, and then they get a second phase of their illness where it's now a bacterial infection needing antibiotics a lot of the time. Once in a while, there's other stranger pathogens that we'll see, like tuberculosis, nocardia, group A strep, Neisseria meningitidis, fungi. Some other pathogens can be related to travel or immunosuppression or specific risk exposures, etc. So always be on the lookout for other risk factors for some of the more unusual pathogens as well. I think we all pretty much know how pneumonia presents. They have a new cough, new pulmonary symptoms, fevers, chills, sweats, sputum production, pleurisy, dyspnea, etc. Sometimes you can have a localizing finding on their lung auscultation, not always. And then kind of like I already talked about, some people get the viral infection, they'll be sick, they'll start to get better, but then they get the double worsening effect. And that's where the bacterial infection has seeded and taken off at that point. We often look for people with COPD exacerbations, and we have to think like, is this an infectious cause of their exacerbation or not? I'll just touch really briefly on pneumonia triage, but there's the pneumonia severity index, where you put in a bunch of factors, and like there's a lot of online calculators. I put one on here, but it's in up to date in all sorts of places. But it's an index where you put in the factors of the patient, and it helps guide you on whether this person can be treated as outpatient or whether they warrant admission to the hospital. A lot of those same factors and criteria also go into the PORT score, the Pneumonia Outcomes Research Team score, and you can look at the percentage, the mortality percent in the right-hand column. For class 1, 2, 3, it's fairly low, but it really takes off and goes pretty high for mortality percent after that. So that's another useful tool to just kind of help gauge what the nature of their care should be moving forward. Okay, now for the really meaty part of this talk. This is why I love doing this talk. We're going to talk about the diagnostics and their limitations. A lot of people, if they stay in the outpatient setting and they're not real sick, they don't get this full diagnostic workup. But if they're going into the hospital, this is a fairly typical workup that we see nowadays. Chest x-ray, sometimes they end up needing a CT scan as well. Also sputum culture with gram stain. Blood cultures, if they're inpatient, they should definitely get a set of blood cultures. PCR testing, procalcitonin, which I have a love-hate relationship with, and I'll explain why. And then some people do urine antigens for Legionella or pneumococcus, kind of depending on their availability and their patient's risk factors. And then we also see a lot of MRSA and NAIR screen with like the PCR swab just to help with vancomycin use or not use. Okay. So the first diagnostic test let's talk about is the chest x-ray. The patient I presented earlier, he's on dialysis, and so he's at higher risk of having pulmonary edema, which makes things, confounded. And so his chest x-ray may show fluid versus an actual infiltrate, and it's not always that easy to tell. You often can't tell whether it's fluid, infection, ILD, or some other prior lung damage that may have been there already. In certain atypical pneumonias like chlamydia psittaci and chlamydophila, they often have completely normal chest x-rays, even if there's a significant infection in them. Other atypicals like Legionella and Mycoplasma can often have infiltrates, but they're often underwhelming infiltrates early in the course of the disease. With Legionella, if it progresses rapidly, you can have a really impressive chest x-ray, but early on it can be pretty underwhelming. So when you're looking at a chest x-ray like this and the read that says cannot exclude infection from the radiologist, you often have to think about, they came in with a new cough, they've gotten very sick acutely, they're septic, they have a white count, etc. We're going to lean on calling that infection for now. So you kind of have to interpret it in the context of other clinical factors. A note about follow-up chest x-rays, just be aware that you usually don't need them if the patient is improving. If the patient's clinically improving and you can see that at the bedside, that's all the information you really need, because a chest x-ray's improvement usually lags fairly far behind their clinical improvement. So people sometimes will check them and then scare themselves and say, oh, we need more antibiotics, we need to give them a longer course, but that's overdoing it. Okay, that's all I have on chest x-rays, but let's move on to procalcitonin, which I already said I have a love-hate relationship with. So procalcitonin, you have to use it very carefully in very specific contexts of care. Otherwise, you can really end up going down a rabbit hole with it. There's mild elevations that can be caused by some localized bacterial infections, also some non-infectious inflammatory syndromes, and also in dialysis or in end-stage renal disease patients. Some of the localized infections that can elevate it include tonsillitis, minor soft tissue infections, abscesses, some CNS infections that are focal. other things like appendicitis or cholecystitis. And then one of the things that confounds it is that it is renally cleared. It is a molecule that is renally cleared. And so if a patient has CKD, it can build up in their system without having an actual infection present. But then if that patient is on dialysis, it is a dialyzable molecule. And so we can see it come down in those dialysis patients. Some patients, if it's getting checked way too regularly in that situation, you'll see it actually kind of come up and cycle with dialysis usage. And that kind of hints that it's a largely renally driven process for elevation. Let's see. So for higher levels, that's like greater than 2 nanograms per milliliter. Bacterial sepsis or severe localized bacterial infections can definitely elevate them. You can also have non-infectious processes that are inflammatory elevate them as well, such as major burns, severe trauma, lots of major surgery, rhabdo, heat shock, pancreatitis. And given that the procalcitonin is actually produced in your thyroid, certain thyroid disorders can also elevate it, and certain autoimmune disorders as well. Multi-organ failure, especially renal or liver failure, can also on their own elevate the procalcitonin. So this is why I kind of preach to people, like, there's a lot of confounding factors. There's a lot of non-infectious processes that can cause a false positive as far as infection. And then there's also infections that can cause a false negative as well. The times that I like to use it is in a well-selected patient that doesn't have these confounders. And then I usually use it for bacterial versus viral meningitis. And then community-acquired bacterial versus viral pneumonia. Those are really the two situations where I have faith in this test, but you have to really select the patient's situation carefully before you interpret that test. So there's a few other ways to use it in the literature, but I generally don't use it in those situations. I'm hoping that in the future we'll have better biomarkers, but we're not there yet. Some courses of treatment are actually adapted according to the trend of the procalcitonin. For a while there, the European guidelines for pneumonia actually did this, and they provided a more tailored course of antibiotics based on it, but that's not commonly used in the US. We tend to just kind of treat for the worst case scenario, and we often overtreat with antibiotics. So I will also say, in certain well-used situations, you can use procalcitonin for stewardship, and it can be very useful then. But you have to have the right patient and the right scenario. Okay, I have been schooled, like especially multiple times in my early attending years. I got schooled on this multiple times, kind of hard. And I would stop antibiotics because I was like, oh, the procalcitonin is negative. And then the next day, the patient was found to have a lung abscess. And I learned like the really focal lung infections, empyema, lung abscess, some atypical bacterial pneumonias, and infected pleural effusion, those things can have a negative procalcitonin, even when there is a raging lung infection. So take that, that's the big caveat with lung infections and the procalcitonin use. Okay, we're going to move on. I've had my angst out with all the procalcitonin stuff. Let's move on to sputum cultures. So the patient case that I presented earlier, altered mental status, can't follow directions, can't give you a sputum culture, that kind of thing. I feel like we see this a fair amount. And I know I have driven a few respiratory therapists nuts by trying to order induced sputum, and they're like, we just can't do it with this patient. You're just not going to get a decent quality sputum sample, which is totally fair, honestly. Like, it's a limitation of certain patients just not being able to do what they got to do to give you a good specimen. Some people have very poor pulmonary toilet, and that's part of why they get the pneumonias too. So just be aware of that. The epithelial cells in the sample can indicate poor quality of the sputum sample. In my PEDS ID training, this is kind of interesting, but their sputum samples have a higher degree of accuracy depending on the size of the child. So in an adult, we're often ending up sampling up here when the lung is infected down in the base, and it's like a foot difference. In little kids, it's usually only a couple inches, like the really little kids. And so their sampling is actually more accurate just because of the geography and the distance of sampling to pneumonia site. Let's see. Non-invasive testing. There's limitations there. Sometimes semi-quantitative samples can be done. A lot of places don't do that yet though. And so you just get, here's growth of something. But having 4+ versus 1+ can be kind of helpful in knowing whether it's truly the driving pathogen or not. Also bronchoscopies, a lot of people don't need them, even though it is probably the best diagnostic method for getting down close to where the pneumonia is and getting a decent sample. You don't want to put somebody through that procedure. Sometimes people are in such respiratory distress that it's just not, going to serve them well ultimately. And so we don't have great access to getting great sampling, even under the best scenarios, unfortunately. Okay, the next diagnostic test to pick on. I'm just kind of going through the line, like picking on all of these diagnostic tests and talking about their pitfalls, but that's the point of this. Urine antigen testing. So the two things that we test for are strep pneumo and Legionella. So like I would say, don't usually do this on outpatients. Like a lot of inpatients may not even need it necessarily, but be aware that with the pneumococcal antigen in the urine, it can stay positive for up to 6 months. So if they've had several recent pneumonias, you don't know if that positive test is representing their current infection or a recent infection. That's an important distinction there. So be aware of that if you have somebody that gets pneumonias regularly. Also on Legionella, it only really covers one serogroup, and that's the most common serogroup, but it's still only one. There's actually 15 serogroups, and then there's also other species of Legionella. So that test is limited in just its spectrum of detecting the Legionella pathogen overall. Basically what I do with these things is I kind of look for the risk factors for Legionella. Have they traveled? Have they been part of an area that's had an outbreak or something like that recently? And that's when I really like to use that test because I think it's more valuable. Okay. Let's see. PCR testing. I like PCR testing, but it is crazy expensive. It is very sensitive though. And it's often the thing that is positive when other things are not positive. That said, I would only use it when a patient is considerably ill in the inpatient setting. So we have these smaller panels nowadays that I think are actually really great ideas, where they look for the pathogens that have specific antiviral treatments. And those would be flu A and B, RSV, and COVID, of course. I feel like those are really where the money's at. There's a lot of other viruses on these larger panels, but ultimately it's just supportive care for those other viruses. They do test for some other bacteria that can be helpful. But as far as the viral testing, I feel like this small panel is really where the money's at. Okay. Sometimes you can still have sampling error with them too, just depending on how good of a sample you can get from the patient. Okay, a few other pearls. If you have a patient with a lot of lung disease, a history of a lot of lung infections, a weak immune system, things like that, their differential is often much broader. That's when you're looking for the weird things like nocardia, TB, some more unusual bacterial pathogens, gram-negatives that are more unusual, things like that. Those patients, I always have to stop and think, like, what are their risk factors? I'll often do my nerdy infectious disease exposure history and see if there's other things like Coxiella or Brucella or things like that to be testing. And they often have protracted courses of treatment. They often don't respond to antibiotics like you would expect, but that should be a little red flag in your mind saying, maybe I'm not hitting the pathogen that we need to be hitting. Maybe we're not diagnosing something that's needing to be figured out. Let's see. Interesting fact, up to 70% of pneumonias never have a fully identified pathogen. So That's a huge number in my mind. And that tells me, again, even though this is a very old diagnosis, we've been treating pneumonia for thousands of years, although not with antibiotics until recently, we still have so many limitations in understanding and appropriately managing pneumonia. 70%, we don't have a pathogen identified. And in those situations, we usually end up just doing a therapeutic trial of antibiotics and hoping they get better. And if not, call ID. So yeah, that's probably one of the biggest takeaways of this whole presentation. We're still just not that good at figuring these things out. In a lot of places, we check the MRSA PCR of the nares to see if we need to do vancomycin or not. I find that that's been very useful because this is all one continuous tube. You're sampling the nares, and it's continuous with your lungs. It's very, widely related microbiome in some ways, but not all. And so that's been pretty well supported in the literature lately for pneumonia, not for other sites of infection, but for pneumonia at least. Know that for some reason, MSSA tends to be particularly gnarly as a secondary infection after influenza infections. So just be aware of that. Okay. So as far as definitions go, this talk, when I originally put it together, I talked about CAP, HAP, and VAP, the hospital acquired and the ventilator associated and that sort of thing. We're just focusing on CAP today, but know that the definition for community acquired pneumonia is no sniff or inpatient hospital exposure in the last 90 days. That is the definition. Let's talk also about the definition of aspiration pneumonia versus pneumonitis. These are related, but it's important to make that distinction because one's an infection, the other is not. They can both cause fever and leukocytosis, but the pneumonitis is really just a chemical inflammation of your lung parenchyma, and that doesn't warrant antibiotics. It can be a bit tricky to distinguish those two things, but the bottom line is with pneumonitis, they usually recover within 36 hours. So all you have to do is watch. Time is the best diagnostic test for differentiating those two things. The risk factors, I'm sure a lot of us know, it's elderly patients, decreased mental status, difficulty with swallowing of any form, vocal dysfunction, recent vomiting, that sort of thing. And if a patient has a macro aspiration event, let's say there's a nurse at the bedside and they witness them choking on their Cheerios in the morning or something like that and aspirating into their lungs, know that 75% of those patients are just fine. It is just pneumonitis. It's not necessarily needed to start antibiotics on those patients after a witnessed event. Some of them, 25%, do go on to end up with a bacterial pneumonia, but doing antibiotics either as treatment or prophylaxis is really not warranted. So just be aware of that as well. When they do get an aspiration pneumonia, like a true pneumonia from it, anaerobes are a bigger factor. There's some ongoing deliberation on whether they're at higher risk with certain situations for gram-positive anaerobes versus gram-negative anaerobes, which can also alter your antibiotic selection, but just know that anaerobes are the major consideration in a lot of those situations. Okay, next up. Here's my pretty spectrum of antibiotic activity card. I know a lot of people love this, and it's a good teaching tool just to help people understand what is covered by certain things. All righty. I have a couple slides here just on antibiotic warnings, because putting somebody on the wrong antibiotic can really make their situation worse. In some situations, linezolid is perfectly appropriate, especially if it's like a MRSA pneumonia, a true MRSA pneumonia. But linezolid should not be used, it should not be used lightly. It is notorious for causing drug interactions. I've had patients end up with serotonin syndrome on it, myelosuppression, liver and GI toxicity. I've had several patients over the years be admitted for toxicity from linezolid. So we got to be really careful when we use that drug. That's usually an ID to prescribe only kind of situation. Also, I've seen a number of people be put on carbapenems automatically, and that's not usually necessary. Some people do have severe beta-lactam intolerances, and ertapenem can be used for those situations. But by and large, we do not think they're needed, and we don't want to use them because we don't want to risk developing carbapenem-resistant organisms, because those turn into a bigger bear to try and tackle over time. We've had a few cases of CRE here in Montana lately that I've heard of. And so I think just trying to avoid carbapenem use that's unnecessary is a good idea for that situation. Okay. Let's also talk about quinolones for a second here. Levaquin, Cipro, moxifloxacin, I feel like these also get thrown around without the due appreciation for their toxic effects. There's also the issues of them having very low thresholds for bacteria to get resistant to them compared to other things like beta-lactams. Yeah, I don't like seeing MSSA be treated with Levaquin. That drives me nuts. It is not a good idea. It is the only agent class that is effective against Pseudomonas. So trying not to overuse them so that we mitigate our risk of having resistant Pseudomonas is a good idea, because otherwise those patients have to be on IV antibiotics, etc. In the last probably 5 years, there's been quite the uptick in black box warnings for Levaquin. And these include things like aortic dissection, yikes, tendinopathy and rupture. Some of that can be reversible, but not always. I've had patients be permanently disabled because of Levaquin toxicity affecting their tendons. It can also cause CNS side effects, peripheral neuropathy, etc. And this is usually, these are usually side effects that happen in elderly patients. So when I'm prescribing, when I'm in a situation where I have to prescribe or I'm considering prescribing Levaquin for an elderly patient, I always think twice, because it can definitely end up not being worth it in some situations. So, okay. I think we're on to just take home points. I'm sorry I've motor mouthed through all of this, but it's a lot of ground to cover on a very complex topic. Okay, so just a few take home points. Know the limitations of the diagnostic tests that we use for pneumonia. And again, 70%, we never really have a full grasp on what the pathogen is. Be really careful with the procalcitonin. Pick the patient and think about the confounding diagnoses before you order it. It's often not useful for a lot of situations. The best way to accurately diagnose the microbiologic agent for pneumonia is with direct sampling, which is just not feasible for a lot of situations. So we just have a pure feasibility situation there. Be aware that respiratory samples have a lot of limitations, especially if it's not accurately brought up, you know, by the patient that's mental status, you know, diminished, that sort of thing. Okay, yep. Aspiration pneumonia, you treat that with antibiotics, but you don't treat aspiration pneumonitis with it. Pseudomonas double coverage. It's really only needed in a few select situations. And that's when the patient has a personal history of a MDR Pseudomonas, or if they've been in a unit where they have high risk of MDR Pseudomonas. And then the last kind of guiding principle here is use your local antibiogram to select your antibiotics. There's usually protocols. The healthcare associated and ventilator associated pneumonias, they have very meaty, very well thought out protocols because the pathogens are a lot more aggressive and more drug resistant usually. But for a community acquired, you still want to use your local antibiograms. All right, that was a lot. So I'll open it up for questions. I'm sure there's going to be some lively discussions here.
Dr. Stevens, that was excellent. Thank you very much. And you're correct in terms of a lot, but I think you encapsulated it very nicely. Any questions out there that are just, you know, that stem from that great presentation there? There's got to be something out there that you guys are. I'll start it off with a couple of any queries or questions for you. So if someone's going to triage, even if it's an upper respiratory tract infection, and try to separate viral from bacterial, some of the old components, like, is there a cough, is there pain, is there an exudate, you find pus, and is there a fever? Is that still valid? Can you initially triage that and use that kind of a those components to triage your patients?
I feel like a lot of the triage is really more to do with the risk of how severely ill the patient will be. And so even if you can kind of gauge, maybe it's viral, but we're not totally sure, like that's often how it goes in the ER. It's like, we're just not sure. We have a procalcitonin that's 0.6 in the patient I presented. And it's like, well, it's not convincing, they're on dialysis. It's like, you always have to look at the confounders. And if I'm not convincingly willing to exonerate the patient from a diagnosis of bacterial pneumonia, then I usually go ahead and prefer to start antibiotics and see if they respond. Yeah, a lot of the time things are just too confounded. If the risk is high enough, you just go ahead and put them on antibiotics and do a therapeutic trial, essentially, see if they improve. Yeah, risk is an underappreciated driving factor for a lot of these patients.
Sure, great. Thank you.
Go
ahead.
Oh, no, I just want to kind of add a little bit to what Dr. Stevens had commented.
Sure.
From my perspective, what I see for many of the frontline clinicians and such is more, there is the risk. And I think that the question that you brought up is, does this patient have pneumonia? And does this patient have pneumonia that will require antibiotics? And those are usually the kind of the questions that frontline clinicians are really presented with. And as Dr. Stevens had pointed out, this is pneumonia is really a diagnostic challenge. Most of the time it's diagnosed clinically based on a series of symptoms, like some of the ones you brought up, right? Shortness of breath, productive cough. And then and clinicians may choose to follow up with like a radiologic test, like chest X-ray, to say, oh, there's an infiltrate. So you put those two together, you have a pneumonia, that this patient may have pneumonia. And now, and there are some studies that kind of suggest how specific are those symptoms in actually making a diagnosis of pneumonia. And and I don't recall the most recent ones, but I know that it's not that great. I mean, a lot of times it's just because even with our best attempt to try to find ways to improve our diagnosis of pneumonias, they're still not that great. And that's kind of why all these other diagnostic tests that Dr. Stevens had brought up had evolved, right? Procalcitonin, respiratory, the PCRs and such, to help us improve with that. So ultimately, in the end, it's like, and I'm kind of putting on now the stewardship hat and how we can help, how our audience can kind of develop intervention, is that, this is something that's really hard to try to convince clinicians to get away from, try to find a good way, because there's just not one very specific diagnostic way to diagnose pneumonia. And a lot of this, and that's where the challenge comes down to, is that, many clinicians, in the end, because there's no great way to do this, they favor starting antibiotics, because it's better to just go ahead and do it and beg for forgiveness later than to ask for permission. And that's kind of what a lot of docs do. So I know that's going to be a question many of you in the audience going to ask, is how do I get my clinicians to do better with their diagnosis? And the answer is, it's going to be really hard, because part of it is we don't have a good way of testing. The other is that many clinicians have already ingrained in their minds how pneumonias are diagnosed, and trying to undo that is a daunting feat. So just kind of bear in mind, this is not something we can easily answer. So don't feel like if you can't get your docs to do better that you're a failure, because everyone shares this challenge. So.
I wholeheartedly agree. Thank you, Neil. Yeah, I feel like in low risk patients, you might have a little more wiggle room to try, give them a couple days, see if they, without antibiotics, see if they improve. But the higher risk patients, I feel like you're really stuck. It's like, well, if we don't start an antibiotic, we do run a significant risk of them worsening and we miss our opportunity to intervene. So yeah, well said, Neil. I am seeing a question about azithromycin for inpatient CAP that I'd like to address. In my crazy ID brain, azithromycin has really 3 functions. It's an anti-inflammatory. It can cover pneumococcus and some other gram positives, a few other gram negatives, but then it has very good atypical coverage as well. Now in Montana, I know when I was at Benefice, they actually still tested for azithromycin susceptibility for pneumococcus, and it was about 50% resistant. So the thought of treating pneumonia with just azithromycin just completely went out the window. So for my practice, if you suspect an atypical pneumonia, I think it's reasonable. Anti-inflammatories, there's other things you can do. I don't really like using it for an anti-inflammatory purpose, even though it is effective for it. I think having it be paired with something like, a beta-lactam, a lower generation cephalosporin, something like that is very reasonable for a straight up community-acquired pneumonia when you know that they need antibiotics. What do you think about that, Neil?
I mean, the original reason that this was the macrolides like azithromycin was added is for that atypical coverage, and that includes like Legionella, the Mycoplasma chlamydophila, and all those more or less commonly encountered drugs and bugs. Now, and part of the rationale too is that they're not really easily identified. You can't culture a lot of them, so you can't grow them. I was going to comment about urine Legionella antigens. It's not that particularly sensitive. It has a great positive predictive value, but terrible negative predictive value. And that's not just because it's not a very sensitive bug, but it also only detects one serotype. So you have, and that's actually kind of a lot. You could still use it, but I just don't use it because it doesn't have much of a bang for the buck, so to speak, because, and there are actually better ways to detect Legionella than just urinary antigen. So, and so my point being is that many times we do this is because like me, just like the difficulties differentiating between viral and bacterial pneumonia is that we don't have a great way to detect that, especially up front. But also keep in mind, and this is, I see this happens commonly, is that once someone gets admitted or gets treated with pneumonia, many times clinicians don't follow up with further studies, right? They just diagnose, here's your antibiotics, let's just see what happens. So, and I think that's kind of part of the rationale. If someone's getting worse, let's say if not getting covered, there was kind of justification to put them on these so that they don't have to do it, because especially on an outpatient basis, you're not going to follow up with that to see, oh, well, if you're not getting better with, let's say, a beta-lactam, maybe we need to get a macrolide on top. No one does that, right? Because for just simplicity's sake. So many of the guidelines are kind of just ended up being, okay, you have a beta-lactam plus a macrolide, more for practical purposes rather, even though, yes, from logistically, we should use it only if we identify a pathogen that would require that antibiotic, if that makes sense. So, and this is one of the challenges with doing stewardship with, at least from my perspective, with at many facilities, is that as you're kind of guiding your clinicians, if you're going to want them to be to prescribe a specific antibiotic, you have to find a way for them to be able to identify the bug to use. Otherwise, then you're kind of leaving this gap. So it's kind of a damn if you do, damn if you don't situation. So.
Great, thank you. There's another one out of the chat box here from Amy Ross. How do you distinguish between pneumonitis versus pneumonia due to aspiration?
also a slightly tricky one. And what I would advise is just giving them time. A lot of the time, that time is the best diagnostic tool for these situations. And some patients will aspirate and feel totally better, back to normal the next morning. Sometimes people take a little bit longer. And like I talked about earlier, it's like a 36 hours usually for most people to get back to their baseline if it's just pneumonitis. In these situations, I say just watch them, see if they do rally and get better. But if they don't, then you probably need to do more of the pneumonia workup. But yeah, time is our friend on those ones.
And I agree with Dr. Stevens, is that, again, the biggest challenge is convincing your clinicians to hold off, right? And this is going to, and I struggled with that as well at Billings Clinic, is that, you know, when an aspiration event that occurs, and or especially if they're a witness, then instinct for many clinicians is to start antibiotics because of that fear. And this is where having a team, a stewardship team, especially with like an ID pharmacist, to kind of help guide that, to kind of help reinforce that, hey, I recognize that you got this patient who may have just aspirated. Could we just wait? And offer that reassurance and kind of follow with that patient, with them, so that they don't still feel that nervousness if I don't do something bad's going to happen. Because not, even though from our perspective, doing nothing is actually better than doing something, but in many clinicians' point of view, it's doing nothing is bad. so this is where kind of a little bit of hand holding will need a little bit of hand holding to kind of help with with encouraging them to wait and watch this patient before starting antibiotics.
I would also say that this, in my mind, this is one of the areas where nursing education would go a long way, because if the nurse is like really freaking out over this and kind of driving the physician nuts, then sometimes there is an element in practice where it's like, we just need to calm the nurse down too. But if we educate the nurse and say, yes, they had a big aspiration event. It's okay, because 75% of the time they just rally on their own. They don't need antibiotics. Like, just telling the nurse, like, it's okay. Like, we don't need to do anything urgent right now. And just having them be aware, like, we are aware of the situation. We're watching this, but we're going to give them 36 hours to demonstrate whether they go the pneumonia route or just the aspiration pneumonitis that recovers route. So yeah, this is a major target for nursing education.
Right. So another one from Kirsten McNerlin. I'm still observing that 70% of pneumonia does not have a known pathogen. It makes it challenging to know if any of these patients may need isolation. Any thoughts around this?
I feel like if somebody has any sort of suspicion of a pathogen that can be transmitted, then droplet isolation is definitely very reasonable. The problem is when we put patients in the hospital, they're coughing, they don't want to wear a mask, they're having trouble breathing, that kind of thing. And so it's like they're going to automatically kind of contaminate the environment. And so it's the healthcare workers that are the ones more at risk, right? And so, yeah, it is a big question. And I feel like with so many things in COVID, like, we can protect people in the hospital by having policies for PPE and things like that. But then they go home to the grocery store, or, go home to their 4-year-old, like I have, that brings all the daycare germs home. So it's like, we can protect them in one setting, but it's really hard to distinguish, where is the acquisition really happening for the healthcare worker? So I don't know if that's helpful. But yeah, it's like, we can control a few things, but there's a lot that we can't control. And
Sure.
We're not able to really mask a patient in the hospital if they're having respiratory symptoms a lot of the time.
I think, Kirsten, just to kind of follow up with what Dr. Stevens said, this may be, the concern is an infection prevention, you have an infection prevention concerns, this could make a reasonable argument for doing PCR, or like a multiplex PCR testing of patients with respiratory symptoms. Because now you're, in addition to diagnosing a patient with, let's say, a lower respiratory infection, whether it's bacterial or viral, you can also at least identify something that may, like influenza, that may require those, or SARS-CoV-2 that will require isolation. So, again, I mean, I know that Dr. Stephen brought up that as a cost, and it is, doing these PCR testing, they're great, but they are expensive, although they're getting better, but it's still pretty expensive. But if it costs the organization a lot of money because of that concern, either because you're seeing an uptick in transmission within the healthcare system or something to that effect, then yes, you can make the argument that may be an argument to use, more try to, as a diagnostic stewardship to intervention, to more encourage the clinician for all these patients to use this test. And we and that are several facility organizations that I have networked with have done that. So it's not unheard of, although I haven't seen any specific publications specifically for that purpose.
Great. Just kind of on the side here, JC had asked about the different kinds of carbapenemases. That's fun to say, wasn't it? Did we have in Montana? And then Erica had answered. JC, did that answer your question? Or Erica, did you want to add it to anything on that?
Yeah, I'm happy to just jump in. So last year we did have 3 carbapenemase producing carbapenem resistant organisms. Stephen, so I get to say that every day. So
Yeah,
it's a tongue twister. We had 3 reported last year. One was actually a BLA gene, which is a little bit different than our typical carbapenemase producers, but we did have a KPC and an NDM. And then, as you saw, we did have quite a few carbapenem resistant organisms. We had, we're kind of still finalizing some of that data, but we had almost 20 CREs and about 50 CRPAs. So it's definitely something that, is being reported to our lab. Now that I have an epi, Tori Dahl is actually going to help me. We're going to start mapping these so we can get a better visual of where our CROs are coming from. And just kind of playing with the data a little bit more. So more to come on that. I'm very excited for some of the data analysis that we're actually going to be able to perform. And then just a friendly reminder that CROs are actually on our confirmation of disease list for Montana, which means that if you do have a suspect carbapenem resistant organism at your lab, we do ask that those are sent to the Montana Public Health Lab with the antimicrobial susceptibility testing, so the ASTs, along with that. And if you need that criteria of what needs to be sent, I'm always happy to share that as well. And then, Vicki, those are the actual genes. So NDM, KPC, IMP. If we ever work a carbapenemase producer together, that's how I usually refer to it. But those are the types of genes. And we can always do a presentation later on if people are interested in all of that fun as well. Thanks, Vince.
Thanks, Erica. Carbapenemase. I got it. Okay.
Say that really fast 3 times. Fine.
I can't say anything really fast anymore. Just one point that I would kind of underscore a little bit when you were talking about the quinolones, because I agree 100%. Those are a nice classic 2-edged sword as far as an antimicrobial. I mean, they're great when you're using a great situation, but they can quickly get out of hand and cause problems and resistance. So from a drug utilization evaluation or a point for your antibiotic stewardship and seeing if something's out of whack, that's a great class of drugs to start with and look at for sure. Because I agree, those are great when you need them, and when they're overused, they're a menace. Excellent. So any other questions out there that we can?
Oh, just to follow up, Vince,
Sure.
and I think your point is valid, because I'm going to surmise that our audience, the question isn't, is that how do we develop an intervention for their facilities in the management of their patients who get, and I'm just going to say hospitalized for community-acquired pneumonia. And there's two really components to this, right? You got the empiric antibiotic therapy, which is what we're trying to advise, there are practice guidelines out there. I think ATS and IDSA has published those. And this is where we, try to guide where, and try to develop an intervention that will dissuade frontline providers to administer or prescribe quinolones as their first line. And so this is a really point where, whether you want to do it as a order set, or you have like a little handy card where that the clinicians can look at to reference it as such. Because if you look at all like Up to Date and all these other sites, they're going to all say comment about quinolones, but probably the number one driving factor for using quinolones is because it's easy, right? And you're trying to tell people not to use something that's easier to prescribe. It's really hard. And that's part of the reason, and that's why we ran into trouble several years ago with quinolones, because because it was so easy to prescribe, that's where we started seeing increased cases of C. diff infection, as well as those tendinopathy and all those other issues that Dr. Stevens had brought up. So, and bear in mind is that depending on how your clinicians will respond to their intervention, how they respond, and how and you may want to pull them and just to kind of get a sense of how do they determine which antibiotics to prescribe a patient, and how you can influence them into using veering away from quinolones versus quinolones in the initial treatment of the community-acquired pneumonia. I would say that for here in the Billings Clinic, we actually just, we kind of struck that out. We restricted the use of quinolones. And sometimes that's what you have to do, is just restrict them altogether, except for very specific situation. I think we use quinolones for UTIs for certain, and that was it. So just kind of bear in mind is that we're just waiting, but it is easy to use, and that's another one of those things that you may have to pull teeth to convince them to go away, veer them away. Same thing with using big gun antibiotics. That's because the fear of missing something is much greater than any rationale you can provide them to try to dissuade them from using Bosun, because I see that a lot, or vancomycin, or vancomycin. That's commonly prescribed because there's so much fear that we're going to miss something. Right.
I always go by the guideline that Ron Smith told me. For every Godzilla cell that you create out there, there's a gorilla bacter out there that's going to counter it. It's like, that's usually, unfortunately, come true. Excellent. Any other questions out there? I want to be respectful of everyone's time, but certainly if there's any other questions out there, let's get them forward. Great discussion.
Vince, just Erica again. I have a friendly reminder for everybody for the Montana Antimicrobial Stewardship Program and those facilities that are participating. The antibiogram survey is due the 15th of this month. And then Jenner and I will be doing the analysis on it and going through those and all that good stuff. So just wanted to remind everybody that that survey is due this month.
Great. Thank you. Jenner, Dr. Koo, anything else? Okay. Dr. Stevens, any final comments?
I don't think so. I think I'm good. I've talked enough.
Hey, fantastic. I really appreciate that. I think we do too. And so let's sign off. Everybody have a great Easter. See you next month.
Thank you, everybody.